Way to put it in again.
Good afternoon, everyone. I'm just going to remind you quickly to please stay on mute during the program unless you have a question. Thank you all for being here today. My name is Renee Calkins, and I am the Education Manager with the Michigan Center for Rural Health. The Michigan Center for Rural Health is a nonprofit state office of rural health, and a cornerstone of our office is to provide free education to rural healthcare providers. I will be the facilitator of this program, and I would like to welcome everyone today to today's Pediatrics Grand Round.
Okay, I'm going to listen to this grand round.
All right, if you could please mute yourselves. Thank you. Today's activity provides one contact hour of continuing education for social work, community health workers, and physicians. You can see our provider statements there, as well as this activity has been approved for nursing. And I would like to introduce Adrienne Wilkerson from the Michigan State University College of Nursing to continue with the professional development information.
Thank you, Renee. So as Renee said, this activity is approved for one contact hour of nursing continuing education credit, and our provider statement is listed on the screen, which we have to share with you. You can scoot forward. So completion criteria and financial disclosures today. The criteria for successful completion today is that you are participating in the learning activity, and that you complete the post-session evaluation and survey at the conclusion of the session, which we'll share with you at the end. Just a note on that, it is very helpful to us if you're able to complete that evaluation kind of right away. Like ideally right away is when it's most fresh in your mind to evaluate, but we do understand that that's not always possible, so it'll still be open for another couple days. Just the soonest you can get it done is helpful for us to close things out in a timely manner. And then for commercial and financial disclosures, no one with the ability to control content of the activity has a relevant financial relationship with an ineligible company to disclose, and there are no commercial interests associated with today's activity to disclose either.
Thank you, Adrienne.
And then there you go. I was going to say the learning outcome that I want to make note of today for you guys to make sure you know what your goal is for learning today is that you'll have increased knowledge of how structured assessment of parent-infant interactions can provide insight for intervention that impacts developmental outcomes. Thank you, Renee. I appreciate it.
Yes, thank you. And then at the end of the session, we will pop up another slide with the post-session evaluation with a QR code, and we'll also link it in the chat. And like she said, well, if you could do that right away, that'd be great. So thank you. And with that, I would like to introduce our presenter today, Barbara Thompson. Barbara is an assistant professor at the Department of Pediatrics and Human Development in the College of Human Medicine at MSU. She joined MSU in July of 2018. She's trained as a behavioral neuroscientist in social, emotional, and cognitive development. Dr. Thompson and her lab integrate clinical research and basic models to study effect in both typical and atypical neurodevelopment. Dr. Thompson's laboratory investigates social and emotional neurodevelopment using unique translational research approaches with long-term goal of understanding the development and functional consequences of disrupted affective process in young children. So with that, I'm going to stop sharing my screen so she can go ahead and share hers. And I just want to say thank you very much for being here today. We truly appreciate your time. And I know our rural healthcare providers do as well. So thank you.
Absolutely. Thank you so much for the invitation. I do appreciate it. Today, I'm going to talk to you a little bit about what our lab does. As has already been mentioned, we do, in fact, study social and emotional neurodevelopment. So we study it at every level, from genes and molecules through circuitry to the actual behaviors of the children, and then how those children integrate into the community. Our lab takes the perspective that there are a variety of challenges that an individual will face throughout neurodevelopment. The black bar here is to represent what neurotypical neurodevelopment looks like. However, at any point along development, there may be a challenge to the system, and that could be something as simple or as complex as a genetic disruption or psychosocial stressor, environmental exposure, prenatal substance use, so on and so forth. And that disruption can then send the system off towards an altered neurodevelopmental trajectory that can lead to developmental delay. It can add allostatic load onto the system, ultimately resulting in altered developmental trajectory. But of course, there's not just a single hit model. An individual continues to develop over time and is exposed to a number of exposures. And so through the process of just simply time passing or maturation, puberty, additional social supports that are in the individual's environment, those that are on the path for altered developmental trajectory can actually end up showing neurotypical heterogeneity. And of course, that neurotypical heterogeneity is rather broad and diverse. So these are the three objectives. They're lengthy, but ultimately, I want to reinforce that observation of parent-infant interactions in a clinical setting can provide valuable insight into those dyadic relationships between a parent and a child. So I'm going to first start off by our definition of stress. And I am certain that every single individual that is present on this call, and in fact, every single human that I've interacted with, has at one point uttered that they are stressed. So to define, however, what is stress? So there's a variety of definitions. The first is that it can be a non-specific response of the body to any sort of demand. But it's essentially a threat, either real or implied, to homeostasis. And then also, it can be also used as either the stimulus or the response. Goodness gracious, sorry. So we need to make certain that we all understand the difference between stress and stressor. So stressor is always the stimulus, whereas stress can be either the stimulus or the response, but not all stress is bad. And so it's thought that stress exists along a continuum with everything from positive to toxic stress. So of course, that positive is something that is a brief increase in heart rate and brief increase in stress hormone levels. Tolerable is that in which there's a serious stressor in the environment. It leads to a temporary response to that stimulus, but it's typically buffered by supportive relationships for that individual. And then toxic stress is that is defined as prolonged activation of the stress response system in the absence of protective relationships. So this is something that challenges the system and can send an individual off of that neurotypical trajectory. So significant early adversity increases the risk for lifelong problems in learning, behavior, and health. Exposures, significant early adversity exposures are linked with elevated rates of mental health problems throughout the lifespan, including substance use disorders. Children exposed to this significant early adversity are also at higher risk for physical health problems throughout the lifetime. And adversity has lasting effects on brain structure and function. And then poverty and neglect are associated with lower performance on cognitive assessments, language, executive functioning, and ultimately lower educational attainment as well. Significant early adversity impacts a variety of systems, and this is due to the fact of how our neural circuits are wired, looking across the continuum of time for development. The sensory pathways, so vision and hearing, touch, all develop very early, and then language is known to come on board, and then higher cognitive function continues to develop well into adolescence and early adulthood. So anything that happens very early is set to create a cascade of altered trajectory simply due to the fact of what neural circuits are doing in that moment. In the first 3 years of life, any sort of, let me see if I can memo. There we go. Sorry. Woo, going back. Just kidding. So any sort of any type of maltreatment can increase the risk for developmental problems. And so in this study, looking at a number of significant adversities, which are listed here: child maltreatment, minority status, low caregiver education, so on and so forth. As the number of risk factors that the child or the individual is exposed to increases, so does the risk for developmental delays. Seen here in the graph, those who had more than 5 significant risk factors exposed to in the first 3 years of life had a greater than 70% chance of being diagnosed with a neurodevelopmental delay. And those effects are similar to poverty, but maybe even more severe. The risk for adult substance use disorder is embedded in those adverse childhood experiences. These are self-report of adults based on the number of ACEs that the individuals experienced, such that for those who, as the number of exposures increase, the risk for having a substance use disorder in adulthood also increases. Additionally, as already stated, our emotional development depends upon those early experiences. So fear and anxiety are essential to help us detect danger in the environment, and threatening stimuli receive more attention simply because it is a survival mechanism. In the study that I'm going to share with you, this is looking at adolescents who had significant ACEs early in their life compared to individuals who were not exposed to significant ACEs. And the non-exposed group is shown in green. And this was a simple rating experiment in which individuals were asked to rate a picture as to the emotional content that was being displayed. So as we work from left to right, up at the top here, from happy to fearful, individuals were asked to differentiate at what point a face became happy and turned to expressing more fear than happiness. And then working our way down, then it was happy to sad, angry to fearful, and angry to sad is how the emotional faces changed. And in that green group, this is where individuals who were not exposed to adverse childhood experiences rated these images as changing from happy to fearful or happy to sad, angry to fearful, and angry to sad. Additionally, there should be a red line here. The red line also showed that individuals who were exposed to significant ACEs early had the same mark, had the same threshold for where they noted that happy transitioned into fearful or happy transitioned into sad. However, when individuals were asked to mark where angry was transitioning into either fearful or sad, those individuals who had significant exposure rated those faces as angry much longer in time than those who had not been exposed. So all the way out here between 80 to 90% of the content of this face is considered either sad or fearful, but these individuals were saying that these faces looked more angry. And again, that is due to the previous slide, which is fear and anxiety are essential to facilitate the detection of danger. So anger is considered a threatening emotion. We know that brains and skills are shaped by the serve and return nature of human interaction. So around 6 to 8 weeks of age, infants actually start to engage in that dyadic social interaction with their caregivers. And then these serve and return interactions support the development of language and theory of mind, social competence, emotional well-being, and academic skills. And of course, infants engage their most relevant sensory environments very early. Here are two different studies looking at what infants are attending to in their environment. The study on the left is showing you where the gaze of an infant was focused when they were either 1 month or 2 month old. And you can see at 1 month, there is more attention to the general face, but it seems to be around the perimeter of that head. By 2 months of age, that focus really has left the perimeter of the head and is focused on the eyes and the mouth. And then the study on the right also is showing for a 7 to 8 week old infant, a 30-second period in which they were presented with a face stimulus and where the gaze of that infant or that group of infants rested. So these interactions begin very early. And then going back to that serve and return, that coordinated social behavior is thought to be the foundation for resilience, or at least posited by Dr. Ruth Feldman. So the social behavior, that serve and return, that dyadic interaction is thought to integrate the 3 tenets of resilience. And those 3 tenets are here: plasticity, sociality, and meaning. Into social dialogue that then allows the maturation of these systems. So the regulatory system, symbolic, brain, health. And the social behavior can be measured on either the individual level, whether it's the parent or the child, the infant, but it also, the coordinated behavior, the dyad's behavior, is also measured along a continuum. So for the parent, the range of this social behavior, this social interaction, ranges from detachment all the way to intrusion. For the child, it ranges from withdrawal all the way to hypersociality. And then at the level of the dyad is valued from constriction to overlap. And ultimately, right here in the middle, reciprocity, sensitivity, and engagement are what are thought to allow for that social behavior to serve as the foundation for resilience. That coordinated social behavior increase in complexity and diversity across time. So looking across development from newborn through infant, toddler, child, and adolescent, all the way to adult, you can see that the complexity of those behaviors between the infant and then older ages increases, as does the symbolization and mutuality. That parent-infant reciprocity during the sensitive period here, the newborn and the infant, actually shapes that reciprocity for that child throughout development and well into adulthood. It shapes the maturation of the social brain, and it helps support social, emotional, physiological, and regulatory outcomes. During the neonatal period, behaviors that are present and are important to foster include maternal gaze and expression of positive affect, motherese, affectionate touch from the mother, from the caregiver, reciprocity of the dyad. So the caregiver adapts the intensity based on the alertness of the infant, and this helps to shape the cognitive skills. In infancy, between about 3 and 9 months of age, parents and infants begin to engage in that serve and return, the dance, in which gaze and affect, co-vocalizations, and touch are coordinated into dyad-specific patterns. Of course, this helps to shape social, emotional, cognitive development. It also is predictive of that child's social competencies and peer group aggressions during the toddler, preschooler, and early childhood periods. Between the second and third year, there's an increased use of symbolic play in children, which is predicted by the amount of reciprocity that was experienced during infancy. So behaviors in the toddler and preschool eras can be predicted based on behaviors viewed and seen and elicited during the newborn and infant developmental periods. So going back to that social interaction serving as the core component for resilience for an individual, sensitivity is defined as how the parent adapts to the child's arousal and communication. It facilitates social competence, creativity, allows the child to expand play, but it also provides a supportive presence for safety and growth of the infant. So these are behaviors such as, or rather, it influences behaviors such as attachment and social skills. Engagement, however, is from the perspective of the child. And so the degree to which the child is involved or shows initiative, persists in the playing or the communication, maintaining positive affect, and exhibiting social emotion regulation. And these behaviors, this engagement is stable from infancy to adolescence. So the amount of engagement that a child has with an additional individual is stable. The dyad, types of social behaviors that one sees from the dyad to define reciprocity for the dyad, so that there is this mutual adaptation. Remember, back in the newborn phase, it's mom attending to how aroused the infant is, or the caregiver, how aroused the infant is. And fluency, the back and forth, that serve and return is necessary during the interaction. That dyadic code is the most stable from infant to adulthood. An infant who experiences greater reciprocity with parents creates very strong reciprocal interactions with friends in preschool, which enables children, of course, to form new attachments similar to those in infancy. So I want to talk, the reason I gave all of that background information is related to a study that we participated in. I was at the University of Southern California prior to Michigan State, and we had a project that was funded to determine, ultimately the goal was to develop a set of biomarkers to identify evidence of excessive activation of stress response systems in children, but it could be gathered easily by health providers in community settings and be acceptable to parents to help measure resiliency to toxic stress. So it was a 2-site study. The first site was at Boston Children's Hospital in Harvard and Children's Hospital Los Angeles. Both of those locations, both of those hospitals had a community clinic from which participants were recruited. The community clinic in LA was Ultimed. So the participants were mother-infant dyads who were receiving care from these community clinics. And the research design was such that it was a longitudinal study. The dyad would come in repeatedly. They came in when the infant was 2.5 months of age, again at 6, 9, 12 months, 18 months, 24, and 36 months of age. Those visits were timed to coincide with the well baby visit. The lab was 2 floors above where the community clinic was located for LA. And then at each of those visits, a number of measures were collected. So the mom filled out a series of questionnaires related to both demographics, her medical history, but also her stress levels and depression and anxiety were also assayed. The infant at every single one of those visits, we did high density EEG. We did a developmental assessment. We did eye tracking and collected all sorts of biomarkers as well. But then that social engagement task was also collected. So we'll get to that in a minute here. So I'm going to just briefly go through some of our findings that we have already published to date. The first paper we published was the EEG data at 2 months of age. And what we found was as early as 2.5 months of age in these infants, there were different brain patterns based on perceived levels of stress that mom had answered during that 2.5-month visit. At that very first visit. So moms who were endorsing higher levels of perceived stress, their infants showed differing brain patterns of activation as compared to those moms who showed relatively lower levels of perceived stress. Our second paper that we published out of this population was looking at the developmental assessment of these kids across the first year of life. We showed that there were actually differing acquisition of developmental assessment of development between the two sites, and those developmental levels actually correlated with some of the basic demographic factors that we had also collected from these families, with both maternal education and community poverty levels experienced in these neighborhoods for these families impacting development. We also showed some changes in infant gaze and affect in the Los Angeles sample. We also published a paper along the top here is demonstrating that we could successfully collect eye tracking data in infants at 2.5 months of age. And so the picture on the left is actually showing that we are holding an infant in front of a computer monitor at 2.5 months of age. And the image on the right, although it's difficult to tell, those are all individual gaze fixations on the computer monitor. So you can see that even at 2.5 months of age, the child is able to participate, and we collected a lot of data from these infants as young as 2.5 months of age. We also showed that the development of attention to that angry bias between the ages of 6 months and 12 months of age changed based on maternal perceived stress. So those moms who exhibited high perceived stress early on, those infants had a much stronger anger bias than those moms who showed low perceived stress early on. That then switches across at about the 9-month age point. So those are some of the publications to date from this study. We are now working on that serve and return, that social emotional connection between mom and the infant. For the 2 to 18-month-old visits, we had mom play with baby in a free play interaction for 2 minutes. There were toys available, but essentially mom was asked to just play with your infant like you normally would. The whole protocol, actually, I don't know if anybody recognizes these images, these still face images up top here, but this protocol that we utilized was the still face paradigm. So in the still face paradigm, mom and baby play together for 2 to 3 minutes, and then mom is asked not to show any affect while she's looking at baby, and not to respond to any sort of bids that the child may make for mom to respond. And that's the still face period. And then there's a reunion phase. And depending on the age of the child, that absence of affect from mom after being engaged is quite disturbing and can elicit a wide range of emotional responses. However, for the purposes of this talk, we're only going to talk about that first 2-minute free play. So this is just mom playing with the infant, being asked to play with the infant as she normally would. So across the 2 to 18 months, it was a 2-minute free play. And then at the 24 and 36 month visits, mom and toddler had a 10-minute free play with available toys. So we videotaped all of these interactions. We videotaped mom and baby playing together at each of those visits. And then we had to figure out which coding schema we were going to use to quantify the quality of interaction between mom and baby. And we ultimately decided on the CIB, which was designed and validated by Dr. Ruth Feldman. And so the CIB is coding interactive behavior. And the CIB is a global rating scheme from birth through adult. There are a few manuals as you go across time. For the infant, there are a total of 43 scales. So 22 are adult, 16 are for the child, and 5 are for the dyad. And by scales, I mean individual behaviors. So there are 22 behaviors that the parent gets coded for, 16 that the child gets coded for, and 5 for the dyad that are unique to each dyad. And then the scores are determined either by the frequency or the intensity of each behavior, depending on the definition of the behavior. It is a manualized coding schema. It's got strong psychometrics. There are correlations between the CIB constructs and other global coding schemes. And there's predictive validity showing associations between CIB behaviors in early infancy and then later cognitive, social, emotional, moral development. And there's retest reliability across the infant, across time. Prior use of the CIB has shown that the CIB is sensitive to variations in interactive behavior that are related to infant age. Remember that as the infant ages, different behaviors come online, and it is sensitive to cultural settings, whether or not the interacting partner is mom or dad or a caregiver. It is sensitive, and I'll go into some of these, to biological risks, social emotional risks, parent factors, as well as intervention effects. So kangaroo care and massage and dyadic psychotherapy. The CIB can reliably and demonstrably discern between intervention groups. So going back to those mother risk factors, and I've put the scales back up here in the far right. So moms who have a clinical diagnosis of depression show minimal gaze to their infant and minimal positive affect, minimal warm vocalizations, minimal affectionate touch. As a consequence, in those infants show up as less social, more fearful, and difficulty regulating negative emotions. If that parent-child interaction occurs when the child is a toddler, you see more child withdrawal in those offspring, more avoidance, negative mood, decreased engagement. If those children receive some amount of reciprocity from mom, either during infancy or early in childhood, those children show better regulatory outcomes later in childhood, and they also have sensitive relationships with their father. So depending on, it's not just a matter of whether or not mom had a clinical diagnosis of depression, but whether or not mom had a clinical diagnosis of depression, and whether or not the dyad, or whether or not she displayed, the dyad showed reciprocity in that interaction. For moms who have a diagnosis of anxiety, there's moms display high levels of gaze. They co-vocalize throughout the play. They constantly talk during the interaction. There's high positive arousal and frequent touch. The child follows the parent agenda, and there's little supportive presence for security or growth of that child. For moms who have endorsed substance use, these dyads show inconsistency in their interaction. Moms show extreme shifts from withdrawal to hypersociality in that engagement period. And children also exhibit conduct problems, but also inhibition and disengagement, sometimes during a single interaction. So remember here that these behaviors occur on a continuum from the parent being detached all the way to the parent being intrusive in that behavior, in that social behavior with the child. And the child can go along the spectrum from withdrawal to hypersociality, and then of course, constriction to overlap for the dyad. For those child risk factors, so prematurity, anxious moms, when coding those social behaviors, that social interaction, mom looks like an anxious mom, which means that it looks like an intrusive parenting situation. The infant shows immature facial social signals, which of course can lead to difficulty for the mom or the caregiver in interpreting needs of that infant. And the infant then also has inconsistent engagement. What happens then is in coding that dyad, the dyad looks more mother-led, more anxious, caring, and consistently involved. For those infants who are a multiple birth infant, so there's a reduction in reciprocity simply due to limited time of the caregiver, which leads to higher internalizing and externalizing behaviors across the first 2 years of the infant's life. There are gains made by 5 years of age for those children, with parents synchronizing with each child, as well as catch-up of cognitive development and executive function for those child. So there's a delay at the beginning, but these children do catch up. These dyads do catch up. For autism spectrum disorder, parents in these interactions show high sensitivity and low intrusiveness, very little disengagement. Children, of course, show minimal engagement and high withdrawal. The dyad shows reduced reciprocity. It seems to be parent-led. There's very little fluency. There's no back and forth. There's no serve and return for the dyad. And so that interaction is more constricted. And then continuing on for those child risk factors. So the CIB is also sensitive to context-related risk. So the CIB can distinguish poverty, single parent, domestic violence, as well as war exposure. So Dr. Ruth Feldman routinely works in the Gaza Strip and has families who live in the Gaza Strip and continue to have children. And so they code home videos of the parents playing with the children and can show high levels of PTSD by war exposure. And so that reciprocity is associated with less anxiety and depression and fewer PTSD symptoms. That reciprocity is also impacted by the child's ability to use mom's proximity to manage moments of increased anxiety. So this all brings it back to that caregiver-child reciprocity can carry long-term effects on resilience. I told you that there are 43 behaviors, 22 of those are for the parent, 16 for the child, and then 5 for the dyad. Those individual behaviors are then combined into a single construct. So all of these individual behaviors are coded, but then they get summed up for the behavioral construct of sensitivity. So there ultimately end up being 3 constructs for the parent, and that is sensitivity, intrusiveness, limit setting. For the child, all of these behaviors get added up into involvement, withdrawal, and compliance for the child. And then for the dyad, there are 2 constructs used, reciprocity and negative states for the dyad. And so to make it a little simpler, so the parent and the child and the dyad are, and so these are the 8 constructs that I will show you data for. I will mention, however, that for the dyad, there will be a missing construct for a while because that reciprocity doesn't come on until later in development. Ooh, wrong way. So our participants for this study, so I'm only going to show you the participants from that enrolled in Los Angeles, and the marital status. These are primarily partnered individuals. They are significantly skewed towards either high school or GED or less than high school. Remember, we're recruiting out of a community clinic. They were not enhanced for maternal depression. We did not, these are just, we recruited anybody who had a 2.5 month or younger infant at the time. So that for the first visit, they were between 2.5 months and 3 months of age. And then you can see the other care arrangements. For the LA site, we do have primarily Spanish speaking, as well as both English and Spanish speaking. So they were primarily Hispanic, Latinx families that enrolled at our site. For coding, we had, so I told you it's a longitudinal study. These families were participating in a number of other data point collections also at each visit. So at the 2-month visit, we actually had 57 families enrolled at our site, but either the infant fell asleep or the infant was not suitable by the time that we got to the interaction, to the interactive behavior. So we had a total of 53 videos to code, and you can see the number that we had for each of the subsequent visits. So it's a relatively small sample size, but we had pretty strong retention given that it was a 3-year study. So now I'm going to show you a lot of data. Let me orient you to the graphs that I'm going to show you. So the CIB, these are going to be the construct scales, and the CIB is scaled from 1 to 5, again, with 1 either being a very low intensity or low frequency, and 5 being a high intensity or high frequency. And so the parent constructs are shown in red. So this will be sensitivity, intrusiveness, and limit setting. And what is being shown are the mean values for the whole group, but then the individual data points are also presented. The blue is the dyad, or no, sorry, the blue is the child, and then the purple is the dyad. So we will see involvement and withdrawal, but then there will not be compliance for the infant until I think 12 months of age. And then for the dyad, there is reciprocity and negative states. So at the 2-month period, so this is when the infant is 2.5 months of age, this is a 2-minute videotaped interaction. You can see the range of behaviors. There's a lot of variability in the quality of these interactions as early as 2 months. And then it gets even bigger, that range of behaviors. So this is the 6-month data, and then the 9-month and the 12-month. And so you can see the reciprocity really has extremes in terms of dyads that show great reciprocity and dyads that show not so great reciprocity. So we're running the full scale from 1 to 5 here. That's true too for limit setting in the parent. And you can see that suddenly at 12 months of age, the compliance scale comes on. You can see the compliance of the child also ranges in a great amount. So that's the first year. I'm going to show you the rest of the data now also. The 18, the 24, and the 36-month data. You can see that variability continues. That variability is also pretty steep for the negative states for the dyad. We have dyad interactions that are rated pretty high for negative states, but we also have families who are scaled very high for reciprocity as well, the dyad. So you can see there's a lot of variability at every single time point. I'm now going to make this, I think, a little easier to view, but I really do think the individual data points are necessary for you to understand the next graphs. So this now is showing the developmental trajectory for the parent composites on this scale. So from 2 months all the way to 36 months of age. The top bar here is the parent intrusiveness. This is the parent sensitivity. And then, nope, sorry. That was limit setting. Limit setting was high across all time points. The sensitivity seemed to be pretty stable until about 24 months of age. And intrusiveness stayed at about the same level also across the 2 to 36 month time frame. So here are the child composites across time. And you can see that this is where compliance comes into play at 12 months of age. There is no compliance earlier. It's just not a behavior that is scored. There are no behaviors to go into that construct. But then here is involvement in the dashed line, and here is withdrawal. So you can see that there is a jump in involvement at about 18 months of age. Between 18 and 24 months of age, there's a jump here, and that seems to correspond also with the jump we see in sensitivity for the parent from 18 to 24 months. You will also remember that this now becomes a much longer play period for the child, and they are now both on the floor together, whereas for the 2 to 18 month, the child had been sitting in a chair. And then here's the dyad across development. So from 2 to 36 months of age, you can see again this jump in reciprocity and this decreased jump, this drop for negative states. So that's the entire group averaged together. So if I were to show you this data, you would think likely that our parents must look similar, our kids must look similar, and our dyads it must have been really boring to code all of these behaviors, to code these videos. And I will remind you very quickly, that was not the case. We have great variability in the individual data points, but as a group, it's pretty small. So the next question was, well, are these constructs predicted by any of those demographic factors that we took? And we focused on the demographic factors and data that we had seen were relevant for the developmental assessment. So in the paper that we published looking at cognitive development in these children, we probed whether or not basic demographic factors impacted those scores. So we used just a few for the pilot statistical testing, just to see if we had any association between those demographic factors and the constructs. So I'm going to show you the data for each of these time points again. And along the top are the constructs, the behavioral constructs, with the first 3 being the parent, and then the child has 2 until 12 months. And then the dyad, reciprocity, and negative states. And what is here are the relationships between the individual behavioral constructs with each other. And you can see that they are strongly correlated with each other. So if a mom was intrusive, she was also, what happened was that there was a lot of withdrawal from the child as well. There was also a relationship with reciprocity. So the top half of this table is just those constructs mapping onto the constructs. What we're really interested in, though, were these demographic factors that are down here: marital status, maternal education level, poverty, how mom endorsed her depressive levels at the 2-month visit, what language was spoken at home, and whether or not the child was being cared for in the home or outside of the home at 2 months. And so I've highlighted these two columns. The red is statistical significance less than 0.05, and then in blue is statistical significance less than 0.1. And the reason why I went ahead and highlighted the 0.1, because it is a smaller sample size. So again, these are just exploratory correlations to see whether or not, to give us a better overall idea of what is impacting behaviors, either of the mom or the child or the dyad as a whole. And so what you can see here is that marital status impacted both intrusiveness and limit setting, and maternal education impacted child withdrawal, as well as the dyad negative states. At 6 months of age, we have that poverty impacted intrusiveness, and that's the only thing. At 9 months, we have maternal education impacting sensitivity. We have childcare at 2 months that impacted intrusiveness. Absolutely nothing at 12 months correlated. And then at 18 months, we had poverty again impacting sensitivity, somewhat impacting involvement of the child. At 24 months, poverty, sensitivity, and negative states for the dyad. And then at 36 months, marital status impacting intrusiveness, negative states, limit setting, and poverty, though not statistically significant, and the EPDS impacting intrusiveness. So to summarize and put it all together in one table, we have the age of the infant, we have the variable, the demographic variable that was correlated, and then either at the level of 0.05 or between 0.05 and 0.1, or actually just less than 0.1. So it's still a pilot analysis. There are much more complex analyses that we need to do for this data set, and I'll go over those in a minute. But it does look like intrusiveness and poverty seem to routinely and regularly get picked up in this preliminary set of analyses. So, as mentioned, there are more complex analyses that need to take place. Statistical modeling, the developmental trajectory of the CIB, to ask the question whether or not early environment impacts the trajectory of early caregiver-child interactions, and whether or not the early impact or the early environment can impact the caregiver-child interactions. So I showed you either the individual data points across time, or I showed you that group average. The question really is, for those dyads who have high reciprocity at 2 months, do they continue to show high reciprocity across the entire research study from 2 to 36 months of age? Or for those who showed low, do they continue to have high? For each of those behavioral constructs, we had that question of what do they look like across time? This is what reciprocity looks like for all 53 of those participants, ultimately down to 34 for that last research visit. So there's not a consistent story if you were to look at the developmental plots, right? It's not that every single participant that starts off high stays high, and it's not that every single participant that starts off low stays low. So that's why the more complex dynamical models are necessary. We also wanted to know whether or not those dyadic behaviors predict later child outcomes, such as cognitive development, and whether or not that those behavioral constructs serve as a moderator between early risk factors and later outcomes. So can dyadic interaction be used as a biomarker for resilience? So those are some of the analyses that we have yet to do. A reminder that the caregiver capacities are impacted by both social and economic environments of that caregiver. So if that caregiver is isolated or has a lack of infrastructure, that will negatively impact their behaviors as well as their behavior with the families. Supports to help buffer that include a support system that has family and friends, continuity of care for whatever needs the family have, and of course, economic stability. The ability to change those brains decreases over time. So recognizing and flagging those infants for risk early makes it easier to intervene. And then to note also that negative outcomes can be buffered by social supports, by positive supports. So where the original fulcrum is placed, however, also impacts how quickly something negative can lead to a negative outcome. And the importance that positive life experiences repeated over and over and over again can actually shift the position of that fulcrum over so that there are positive outcomes. Why this matters to you. There it is. This is a great article. So healthcare providers are often called upon to address the needs of children who have experienced ACEs. Individualized data on the effects of trauma for young children would increase clinicians' capacity to provide credible reassurance for families who are actually showing evidence for resilience. An enhanced ability to make referrals to well-matched interventions based on identified effects of excessive stress activation. And then the capacity to measure activation and resilience directly could assist primary care clinicians in deciding which services would work well for some, and then would strengthen the case for healthcare funding of effective interventions. Additional ongoing collaborations for my lab related to this, we are working with Dr. Poland's Great Moms Clinic at Corewell Health in Grand Rapids. We had a collaboration with Pine Rest, recruiting for moms who were endorsing postpartum depression. Before COVID, we're hoping to get that back up and running again. I also have a project, hopefully, that is going to be funded with a collaborator in East Lansing, Dr. Michael Boyven, who actually has been in the Congo providing caregiver training to reduce Konzo disease. And so for all of these, we are hoping to recruit moms and their infants to look at that dyadic interaction. I must give thanks to a number of collaborators, people who have worked in my lab, either coding or recruiting, and then of course our funding sources, our external collaborators as well, our clinical partners. And then I think that is it for me. So I will stop sharing. There we go.
Thank you very much.
Absolutely.
It was very fascinating.
Thank you.
And I'd love to hear more once you guys keep continuing.
Right. We're excited to do all of that. Our hope with Dr. Kara Poland and her Great Moms Clinic. So those are for moms who are endorsing substance use during pregnancy. And Dr. Poland has a fabulous intervention that co-localizes care. And so we're hoping that we can follow those families to show positive benefits for that. Postpartum depression is a great interest of ours simply because individuals who experience postpartum depression tend to neglect infants. And so being able to document whether or not that interactive behavior between the mom and the infant is impacted by that may help allow for a biomarker to exist for that dyadic interaction. So.
That's great. I know we're running out of the time, but if anybody has any questions, please feel free to unmute yourself quickly. And if you do have any questions as well, you can email me and I can always forward those on.
Absolutely.
We have your evaluation on the screen. You can use the QR code or Adrian did just post it in the chat. So please go ahead and fill that out. Your CE certificate will pop up once that is completed and will be also emailed to you directly. So if there's any questions. I know we've got a lot of thank yous. It was very helpful. So far from the monkey attachment stuff. Very true.
I know, right? Yeah.
All right. Well, thank you again for being here. It was a pleasure. I'm so happy to have you. It was
Thank you
great.
for having me. Thank you.
All right, I will go ahead and stay on for a moment to let people use the QR code, but feel free once you guys are done to log off, and I will send a follow-up email with the handout and the evaluation one more time if you've got to hop off and get back to work. And we will see you at our next grand rounds. So thank you very much, Dr. Thompson, and it was a pleasure.
Thank you so much. Take care.
Bye-bye.
Bye.